We turn our attention now to COVID-19. We've called up Dr. Murray Cohen again, an expert on infectious disease. He has, I know you've been waiting quite a while, Dr. Cohen, so I'm sorry to keep you waiting. We've had breaking news and other things going on while we've been trying to get to your interview. So thanks for being patient with us.
No problem, Annie. I'm still thinking about a steak from that last part of the program.
Oh, yeah, I know. Doesn't that sound good? So you've spent a lot of time crafting policy for infection prevention, and you are an infectious disease expert. And as we go forward here with trying to learn about COVID-19 or SARS-CoV-2, which causes COVID-19, what do we know today that we didn't know a few weeks ago? Is there anything new in the world that you live in?
There's new information, new important information coming out literally every day. I think the two most impressive bits of science were published last week, dealing with trying to understand who's immune, or after you've been infected, are you immune, and if so, for how long, from being reinfected again. This is a way we will be able to determine people who can safely move around, even among others who are infected. One piece of data was done in South Korea. It was following up a study done last December or so, published last December in China, where they infected non-human primates, monkeys, with COVID-19, let them resolve the virus, and then they tried to reinfect them, and they couldn't. They didn't get reinfected. So that indicated, since monkeys' respiratory systems are close to humans, that it's reasonable for us to expect humans will get some kind of immunity by living through an infection. Well, they pretty much proved that, published it last week out of South Korea, where they had a couple of thousand patients where they re-exposed them, or they had gotten re-exposed. They followed these cohorts, and they just didn't get sick again. We can pretty much just take that off the table as a problem. The other key finding was a curious part of this virus that has been reported that sometime as much as 3 weeks after resolving an infection, people can get tested, same kind of test, the nasopharyngeal or throat swab, and test positive. And so does that mean they still have the infection, or they're getting reinfected, or what's going on? And a really great set of virology experiments out in the La Jolla Institute of Virology showed that all that positive testing was not viable virus. They were able to get these positive tested patients, take the genetic material, put it in tissue culture, and try to grow it, and it wouldn't grow. Meaning that viral RNA, the genetic material of the virus from when they were sick, essentially still had some, let's call it, biological garbage, like dead cells or whatever, still in the bodies and nasal cavity of former patients, but that they couldn't infect anybody or couldn't reinfect the patient. So these are two really big steps forward in what we're going to have to think about and look for as we're reopening around the country for who can, in fact, safely come back to work and go to school, et cetera, et cetera. Still, there's a lot we don't know about the virus, but these were big ones.
Okay, sorry about that. Speaking of, being tested positive, but then not actually having any viable virus to pass along, could that be the cause of us thinking that people are asymptomatic with it, that it's possible that they had it before and that now they're just testing positive with this genetic garbage or whatever we're calling it?
That's the technical scientific term. I didn't want to get too geeky here.
I like it.
That's a very good question. But again, in order to have the let's call them dead, the viral garbage, you have to have had the virus. So actually finding in people that look asymptomatic or have never reported any infection, and doing the swabs and finding this RNA garbage, you can go, aha, they really were infected. We just didn't see the symptoms. Mm. So you've made the right point, but you got to kind of turn the binoculars the other way.
I got you. Are we finding, what do we know about asymptomatic cases? Because to me, I think that's one of the scariest parts of this virus is that you can be asymptomatic. And sometimes I wonder why we're doing all of these temperature checks and these questions if it doesn't really matter. I could be walking around without knowing.
Well, it turns out that one of many curious aspects of this virus is that it does seem to transmit largely, perhaps mostly, asymptomatically, meaning that it gets into patients and only establishes itself and starts replicating itself and doesn't mess up its patient too much, so it can protect its own, genetic future and then continue spewing out to infect other people. But that's also, flip the coin over, that's also the easiest element to do public health interventions. And that's the reason, for instance, that wearing masks or even a scarf, any covering at all over the mouth and nose, coupled with social distancing of 6 feet, has worked. And we didn't know anything about this virus. I mean, this is brand new. Thank you, God. Hit the earth, in November or December. And everybody in the world is susceptible. So everybody's either going to get sick, die, or not get the virus. So we didn't know what to do. So we put in fairly, dramatic, based on every other kind of virus similar to this, elements of infection control until we learned more about what the virus does. It's just like with medicines. You start with some medicines and you keep trying different medicines until you find something that works. So we were trying public health elements, and as we found strategies that worked, we could stop doing other strategies. Does that make sense?
It certainly does. In fact, Dr. Cohen, that leads into my next question. So we've been putting a lot of eggs in the basket that testing is going to be the way that we can help reopen society for people, especially those who are vulnerable to COVID-19. So my question to you is this. Are we still progressing in the way that we're testing? I mean, at one point we heard about this rapid test, and now we're hearing about possible home tests. Should we still be traveling down that road of improving our testing capabilities, or should we start looking towards other aspects of saying, gosh, we're testing the wrong thing. We should be testing who's possibly had it instead of who has it right now?
Well, testing is the holy grail. Any kind of virus outbreak. So we certainly don't want to abandon it. Testing in the U.S. policy up to now has been a total disaster, a complete mess. The single most important failure is that we don't have a case definition. Usually, when there's an outbreak, first thing epidemiologists do is define, here's what a case is. Here's what we know so far. It would be a fever, sore throat, cough, dry cough, see certain patterns in the lung, and down the list. In this virus, because of the way the strategies have been developed state by state, we have 50 different case definitions. The definition that determines who gets tested. So you can't even look from state to state to compare, okay, well, if 5% of the people who were tested positive, then we have 5% herd immunity. Is that correct? Or immunity in the population? Well, no, because right next door, the number is totally different. And we don't know why they're different. We don't know how they were tested. So testing, first part of your question, the testing is absolutely essential. And what we have to do is get better and more precise with it. Now, a part of, what you said as a curiosity or frankly a criticism is we're throwing everything against the wall to see what sticks. No, we need to have very targeted, systematic testing so that we can interpret the results. Yes, we want diagnostic testing to get the people who are sick and put them in isolation so they don't keep infecting other people. But we also want to know all of the people who now we think have immunity because they've been infected and resolved the virus, particularly asymptomatically. That's a different kind of test altogether. You're not testing to see if they have virus. You're testing to see if they have antibodies to the virus, meaning they've already resolved the virus and now their body's ready to go. Come on, virus, hit me again. I'm ready for you. And that's how we begin to we separate the different kinds of tests, and we define who we're testing and do it systematically so we can determine in a population where the sick people are and how many of them are sick.
Dr.
Does that
Cohen,
make sense?
Yeah, absolutely.
Yeah. Oh, yeah.
Dr. Cohen, going back to the immunity portion of it, we do believe now that people who have been affected do have some sort of immunity. Is there any addendum, because now there's news that there are several different strains of COVID-19?
Yeah. Well, first, you got really two questions there. First, I'll deal with the strains. I have seen phylogenetic reports, laboratory studies showing the genetic drift of this virus so far across the United States and other parts of the world. So far, this is nothing to worry about. This is just the normal life of a virus. Viruses have about 500 million generations across one human generation. I mean, these little babies are changing all the time. They're genetically getting challenged all the time. Things are changing. That doesn't mean that any of these changes actually make a difference in what we care about. It's infectivity, how sick it can make somebody, who can catch it, how it's transmitted, et cetera. It's just, it might be the equivalent of, having more blue eyes than brown eyes, in the next generation,
Sure.
so to speak. It's just normal. We call it genetic drift. So that's really not a problem. Now, the other part of your question was, now that we know people have some sort of immunity, are they immune to all the strains? Well, so far, yes, because we haven't seen the mutations have been any different. I do want to point out, though, that what I stated, with a strong factual basis earlier about these studies last week, what they tell us, you're not going to see that in the newspapers and in the policies that are coming out of the government. Because I'm following a rule that served me very well as an epidemiologist since 1975, and that is you can't let the good enough be destroyed by seeking the perfect. Or another way we say it is, it's better to be mostly right 98% of the time than to be perfectly right once. So this is early data. What you're going to read from, for instance, in the national media will be, can you tell us unequivocally everybody that gets infected is not going to get infected again? And I'm going to say, no, we don't know that. We're still doing studies. And that's true. But all the studies coming in so far are showing that answer. So to me, when I was a policymaker, I said, I've got enough now to make a decision and go forward and act as if that's true and back off if it turns out to be wrong, because it seems so likely it's going to be true from evidence already.
Yeah, well, that is good news. And then I guess, what is the threshold for herd immunity now that we know that?
Herd immunity is a concept. It's not really something you measure. Generally, it's felt that it has to be 70 to 80% of the population, and this is based on demographic statistics. The idea here is if you're a virus and you're floating around and you're looking for somebody to infect, and at least 70% of the people are immune to you, and you're going to keep dying off and nobody's producing more of you, then you're just going to burn yourself out. The outbreak will burn itself out because there's nobody left to infect. And how many people does that take? For a virus like Ebola, where nobody got immune but everybody died, the viral outbreak died pretty fast. Up to the one we had in West Africa in 2014, there were different elements there. But all of the Ebola outbreaks before that was a dumb virus. It killed everybody, so it killed itself. This virus is very smart. It keeps lurking around. So I suspect we're going to need more than 70%. We're probably going to need closer to 80% to start seeing herd immunity. The good news is it doesn't mean we have to do it all this month. This virus is with us. This virus is going to be with us year-round, pretty much forever. And so every season there's going to be new people born or new people coming in who are not immune, and they're going to get sick and spread it around among the few people who in the herd who still are susceptible. And that's just going to be, this Earth. We already know that people get sick all the time, and some unfortunately die, and we're coexisting as peacefully as we can with this virus and all the other microbes.
Dr. Murray Cohen.
But it's not going to wipe us out. But it's not going to, threaten shutting down our entire medical system,
right.
Totally wiping out our elderly population like this virus is.
Wow.
That's scary stuff. We've got a lot more to talk about. I hope we can keep you on board here, and it takes two. We always like hearing from you, Dr. Murray Cohen. Spent 20 years with the CDC crafting policy for infection prevention, and he's an expert on infectious disease. Thanks so much for joining us again. We really appreciate your time.
I enjoy talking with you. Thank you so much for asking me.